I don't know. That's why I'm saying. Okay, shall we start?
Yeah.
All right, good morning. So we'll be talking about bleeding in pregnancy in this session. You are called to the emergency room to evaluate Mrs. Ahmed, a 32-year-old woman. She's para 0+1. Okay, her last menstrual cycle was 6 weeks ago. She presented with a history of fresh vaginal bleeding associated with lower abdominal cramp. She's very worried because she had a previous miscarriage at 8 weeks. Okay, is this something that we see a lot in our practice? Yeah, we see it a lot. She had a positive pregnancy test 2 days ago. All right, her cycles are 5/30 to 35. What does that mean? طيب. How would that help me in the management of this patient? Why are you saying that? صح, that's why.
Normally, I need to calculate 7 minus 1. Her cycle is not the same as the 728.
So her ovulation did not occur on day 14. It probably occurred sometimes later. So although she might be 6 weeks from her last menstrual period, the pregnancy might not be 6 weeks, correct? So this is very, very important information. Okay, because you remember what we said yesterday about the accuracy of the dating and the LMP and all these things. Okay. So vital signs are stable. This is again a very important concept when we are dealing with somebody bleeding. You know, the first thing to do is that your ABCs, you know, you have to make sure that vitally the patient is stable, the bleeding is not heavy, and so on. Examination showed a soft abdomen, mild suprapubic tenderness, and the uterus is not palpable, which is expected, because we said yesterday it only becomes palpable when after the first trimester, so around 12-13 weeks. Speculum examination, mild bleeding was seen, and the cervix is closed. Okay, so the normal thing to do in this case is to perform an ultrasound. What do I want to know from the ultrasound? The baby? Is he even a baby at this stage?
Whatever it is.
The embryo, there's a Bible embryo if you're lucky. What else? Placenta? She's like 5 to 6 weeks. You don't see placenta. What's the most important thing I want to know? Huh?
The age of
Somebody coming with pain and bleeding in early pregnancy. So I want to see if there is an intrauterine gestational sac, then I'll be happy. And whatever comes after that is fine. Yeah, but I confirm that it's an intrauterine gestational sac. So what we saw is a very small gestational sac. There was no fetal pole or yolk sac. Okay, and minimal fluid in the pouch of Douglas. So why we were not able to see a yolk sac or a fetus?
when does the yolk sac?
Okay, that's a very good question. When does the yolk sac appear? Very good. We'll come back to that. So any bleeding in early pregnancy is abnormal. Is it common? It's common, but it's abnormal. Normally, women should not be bleeding. If they bleed, it's abnormal. It's not always dangerously abnormal, yeah, or it means that she's going to have a miscarriage, but it's out of the normality. We always have to ask, when did the bleeding start, the color, and if there is any associated pain. But ultrasound is essential for your diagnosis, okay? It affects 20 to 30% of all pregnancies. 1 in 8 of these pregnancies will miscarry, and 1 to 3% will be ectopics. Exactly. Yeah. So why do you think women bleed in early pregnancy? Why? Miscarriage. That's the most, important thing. What else? Ectopic pregnancy. What else? Guys, placenta previa is not a diagnosis in the first trimester. When do we call placenta previa? It's a third trimester diagnosis. We'll come to placenta previa later. No, there's nothing called placenta previa before 28 weeks of gestation. What else?
Traumatic.
Yeah, it could be trauma. It could be whatever, laceration. Could it be other pathology? Does it always have to be related to the pregnancy? No, she could have cervical cancer, vaginal cancer, you never know. Yeah, what else? Could it be normal, physiological? What is that? What do we call that? Bravo, implantation bleeding. Okay, so implantation bleeding, it's usually a small amount of bleeding that usually happens almost at the time of the next expected period. And where is the blood coming from? Yeah, so it's from the mother, not from the fetus. Yeah, as the fertilized embryo, the embryo is implanting inside the uterine wall. You know that the pregnancy implants in the wall. You know that. Yeah, it's not like cakey just hanging around inside in the uterus, in the cavity of the uterus. It actually implants inside the uterine wall. Yeah. So in order to be able to get the blood supply, otherwise, if it's just hanging around in the uterine cavity, where will it get its blood supply from? So, okay. So it's implanting inside the uterine wall, and as it implants, it might actually go through some of the maternal vessels, and that's what bleeds. So that's why we call it implantation bleeding. And usually the implantation happens at around the time of the next period. So many times women might actually think that it's just a menstruation, but then when she looks at it, she'll say, okay, well, I had some bleeding. It was only for like a couple of days, less than my usual. And then I did not get another cycle, for example. Or I started feeling, symptoms of pregnancy. And then she realizes that that was actually bleeding and it wasn't a period. Okay, usually minimal, can be confused with the normal period, and usually it's of no concern whatsoever. Okay, we said that 15 to 20% of all pregnancies will miscarry, maybe even higher than that if we are looking at very early miscarriages, like, just at the time of the missed period, or just before. And we said yesterday that you can have a positive pregnancy test even before the missed period. So if women actually start doing that, we'll find that a lot of concepts are actually lost. So you might find a positive pregnancy test, and then a few days later, the patient just gets like a normal menstruation. So there was a pregnancy somewhere, but it just miscarried because whatever, the concept was not really normal or something like that. Yeah. The majority of miscarriages happen in the first trimester, and 1 to 2% occur after 13 weeks. So usually we say that the risk of miscarriage, like maybe up to 25% in the first trimester. Once you see a positive fetal heart, that risk drops to like maybe 5 to 8%. Once you pass, 10, 12 weeks of gestation, that risk becomes even less than that, like 1 to 2%. And this is very important when you're dealing with someone who actually has recurrent pregnancy losses, because this is sort of like a reassuring finding, okay? So, causes could be fetal, like 50 to 60% of these early pregnancy failures are related to a fetal chromosomal abnormalities. And remember that these chromosomal abnormalities, actually, if we start doing like chromosomal analysis on all these early concepts, we are likely to find chromosomal abnormalities that we actually don't see in live births well, we don't see later on in pregnancy, just because these chromosomal abnormalities are usually quite lethal. Yeah, and that's why they just don't make it beyond the first few weeks of gestation. Okay. Maternal طبعا, it could be a lot of different factors. Age, obviously, older women are more likely to have miscarriages than younger women. If there's any structural abnormalities such as biconate uterus, fibroids, infections, maybe maternal diseases, poorly controlled diabetes, renal abnormalities, thyroid diseases, antiphospholipid obviously is very important, alcohol, smoking, and so on. Yeah, so there's a lot of different causes that we can't always pinpoint what is the reason. Okay, so what do you think are the different types of miscarriages? Yeah, so it could be complete miscarriage, it could be incomplete miscarriage. What else? If she only bleeds and she does not miscarry, what do we call that? Huh? Threatened, مظبوط. What else? What else we could have?
Maybe it's not properly.
What will that be? Miscarriage, complete or incomplete. So, what else? Could it be like infected? So septic miscarriage, yeah, could be septic miscarriage, or it could be missed miscarriage. Yeah, we'll go through those in a minute. So threatened miscarriage, like what probably our patient has. She has some pain and bleeding. Ultrasound will show a sac, or maybe later on it might show a positive fetal heart. The cervix is usually closed on examination. It's really not related to anything, usually settles with no problems. But obviously, if the bleeding increases, then it might change into a different type of miscarriage. Okay? So this is basically what we will see by ultrasound. What's inevitable? Exactly. So it's a miscarriage that's going to happen whatever we do. Yeah. So usually she, like the first case, but she's going to be presenting now with more bleeding, more cramping. You might see a viable pregnancy by ultrasound, but unfortunately, you will probably see the sac all the way down in the uterus, or even at the cervix, which means that it's on its way to actually miscarry. And the cervix will be open, and you might see the products just hanging there, and the pregnancy is going to be lost, and there is really nothing we can do about it when we reach that stage. Okay? Done. Incomplete. What would have happened in the incomplete?
Something is wrong.
Sorry?
Some products are still up.
Exactly. So she already had a bleeding. She has cramps. She lost already some tissue, but there are still some remaining tissue within the uterus. Okay, so that's incomplete. Ultrasound, you'll see products of conception. The cervix is usually open. And in these cases, it depends on the amount of the products of conception that we see inside the uterus. We will decide whether she will require surgical intervention or not, or even medical intervention. Yeah, usually when we measure by ultrasound, usually products that are less than 2.5 to 3 centimeters, we can consider them. I mean, they're still incomplete miscarriage, but they don't actually require surgical intervention. But what we tell the patient that she's likely to continue bleeding for the next maybe 10 to 14 days, which is expected. As long as it's not heavy bleeding, it's fine. She can just stay at home and she will not need any intervention. Okay? So these are the products that you can see inside the uterine cavity. We just measure the maximum diameter of them, and then we decide whether we need to do any surgical intervention. Okay? And then on the other hand, a complete miscarriage. So there's no product inside the uterus. What will the cervix be like? Khalas, yeah, everything is out. The cervix is already closed, and there's really nothing that you need to do for this patient. Bleeding and pain has resolved, and so on. Okay? So this is basically, you'll see just a nice thin endometrial lining, so everything is actually out. Okay? What's a blighted ovum? Anyone knows? So it's basically a large sac that doesn't have an embryo or a yolk sac. Yeah. Why did I say a large sac? Because if it was a small sac, maybe it's still early in pregnancy. Somebody was asking earlier, when will we see the yolk sac? There are like specific, I think there is a slide on that. If not, then remind me, I'll tell you about it. If it's a small sac, maybe it's still an early pregnancy where you didn't see yet the yolk sac, and obviously the yolk sac appears first and then the embryo. So if it's a small sac, then maybe it's just an early pregnancy. It could be a miscarriage, but it could be an early pregnancy. So we do not rush into the diagnosis of a miscarriage. While a blighted ovum is a sac that is already more than 2.5 centimeters in diameter with the absence of an embryo or a yolk sac. Yeah? So what happened to the embryo? There must have been an embryo at some stage. Huh? Maybe what?
And country of the
It got absorbed. Yeah, because the embryo was so abnormal that it just died off very, very early before we can actually see it. But obviously the pregnancy continued just because, I mean, there are some still trophoblastic tissue or whatever. Yeah, so this is what's a blighted ovum. So usually there's no or little early pregnancy symptoms. An ultrasound, you see a gestational sac with no embryo. A missed miscarriage, on the other hand, is a sac with an embryo, but no heartbeat. Bravo. And again, there must be like specific sizes of the embryos before when we will say maybe it's still an early pregnancy, and after which we will say, no, this is a non-viable sac. So there are some criteria that we need to follow to make sure that we're not over-diagnosing a miscarriage, okay? So with a miscarriage, there will be little early pregnancy symptoms, or there might be symptoms before, but then they disappear. An ultrasound, you'll see a fetal pole with no fetal heart, and it might be asymptomatic, or the patient might present with bleeding, and then you find out that it's actually a non-viable pregnancy. Okay? Septic miscarriage, we don't usually see anymore, but I mean, it used to be because of like illegal, terminations or things like that, instrumentation within the uterus in the presence of a pregnancy. So it's not really something that we usually see. But anyways, it's like any infection that the patient might present with signs and symptoms of sepsis, and you have to treat her like a septic patient with antibiotics. And the most important thing is to remove the source of the sepsis, which is the products of conception. So these cases will require urgent evacuation as soon as you actually stabilize the patient, because there is like a serious infection. And remember, women die from miscarriages. Miscarriages, not even ectopics, huh? Women die from miscarriages. They die from infections, even in early pregnancies. So you cannot take these things lightly. Patients actually go to ICUs with miscarriages. Yeah. On the other hand, an ectopic pregnancy is a pregnancy that is implanted outside the uterus. As a general concept, it's outside the uterus. Yeah. And this could be in many different areas. Yeah. Most commonly, it's in the fallopian tube in like 95% of the cases, but it could actually be implanted anywhere. Yeah. Bleeding from an ectopic pregnancy. Where do you find the bleeding from the ectopic pregnancy? Where do women bleed? Exactly. So it's not vaginal bleeding. Actually, usually in ectopic pregnancy, the patient might not present with bleeding or only very minimal bleeding. But the dangerous thing is the bleeding inside the abdomen, which you cannot see unless you do like, ultrasound or laparoscopy or something. Yeah. And as the pregnancy gets bigger, obviously, the tube or whatever cannot expand like the uterus. So therefore, as the pregnancy gets bigger, you are likely to rupture that organ where the pregnancy is implanted. Okay? From predisposing factors, remember that they're only present in 50% of your patients. So always be aware of the diagnosis of ectopic pregnancy, even if you do not have risk factors. Obviously, if you have risk factors, then you're going to be following the patient a bit more closely. Like, if she had a previous ectopic pregnancy, whether she's known to have like blocked tubes or IVF pregnancy or so on. Yeah, so these are the risk factors: a previous history of pelvic inflammatory disease such as chlamydia, previous tubal surgery, use of IUCD. Why? Why does a contraceptive device has an effect on the risk of ectopic pregnancy?
The uterus.
No, it doesn't. It doesn't block the uterus. What does it do?
Inflammatory.
Where? Okay, so because there's an inflammation inside the uterine cavity, it makes the environment hostile for the embryo to implant. So it prevents intrauterine pregnancy, but it has no effect whatsoever on the ectopic pregnancy. So it does not increase your risk of ectopic pregnancy, but because it does not prevent ectopic pregnancy, and if the patient is already, for whatever reason, at an increased risk of ectopic pregnancy, IUCD will not prevent it. Do you get that? If you're using hormonal contraception, it blocks ovulation. So it blocks any pregnancy, inside or outside. Yeah? Huh?
Why do you have inflammation in the ICU?
لأنه it's a foreign body, so the body reacts to it with like it's not an infection, it's an inflammation. Yeah, so it's like just like an immunological response that makes the lining very hostile, and the embryo cannot really implant in it.
It prevents the inflammation in the uterus?
Yeah. So you could have fertilization, and the embryo actually makes its way into the uterus, but it cannot implant.
But it does not increase the chances of ectopic pregnancy?
No, but it does not prevent it.
Yeah.
You got that? Yeah. That. So 74% occur in the ampullary part. And why is that? Because it's the largest part. Yeah, exactly. And the isthmus, fimbrial, and the interstitial are much less. Okay. Where else could it implant? Yeah. Liver, ovaries. Where else? Bladder. يعني as part of the abdomen, maybe. But where else? Cervix. A cervical pregnancy is considered an ectopic pregnancy. And what more that we see more and more nowadays?
The other side of it.
Other side of the uterus, إيش يعني? Okay, no. In the previous? Uterine scar. So patients who have previous cesarean sections actually might have an implantation into the previous scar. So it's actually embedded inside the scar area. And why do we worry about that? Yeah, and okay. And that area, which is usually in the lower uterine segment, doesn't have a lot of muscular supply. And maybe because of the repeated cesarean sections, it became what? Weak and fibrosed. Exactly. So you're at high risk of uterine rupture. Okay, so it's very, very important if you diagnose a scar ectopic pregnancy, you have to deal with it. You cannot let it continue. Okay, so symptoms often are variable and may include amenorrhea, obviously, nausea, early pregnancy symptoms, pain, which is usually on one or both iliac fossa, usually on one side. Bleeding, like we said, it's usually not a serious issue, just maybe dark bleeding. Dizziness, which might indicate there's an intra-abdominal bleed, and shoulder tip pain. Why? Any intra-abdominal bleed can cause shoulder tip pain. Irritation of the diaphragm, and the diaphragm is supplied by, which supplies the shoulder. Okay, so this is a very common symptom. Yeah. Rarely it remains asymptomatic beyond 8 weeks of gestation, because usually by that stage there's massive stretching or even rupture of the ectopic. Sometimes it might rupture even earlier if it wasn't in the ambulatory part. It was, for example, in the interstitial part. Okay, and what would you when by ultrasound you would see an empty uterus. You might see fluid in the pouch of Douglas. You might actually see fluid all around the abdomen if there's like massive bleeding. And sometimes you might see an adnexal mass, and sometimes if it's even beyond, like, 6 to 7 weeks, you might actually see an embryo with a positive fetal heart in the tubes or ectopic. Yeah. But the differential diagnosis will be a corpus luteum, it might be intestinal polyps, biosalpinx, bicornuate uterus. So obviously you have to exclude other differential diagnoses before you rush into the diagnosis of an ectopic pregnancy. Obviously a positive pregnancy test will help you make that diagnosis. Okay? Done. The HCG is produced by what? The trophoblast, exactly. And the pregnancy test that we do is actually based on the HCG, and they are extremely accurate, these pregnancy tests, that will detect, levels that are very, very low, even as low as like 5, 10 milli-international units. Yeah. So they're very, very accurate. Even the home pregnancy tests actually are extremely accurate. Yeah. So normally, what happens to the HCG as pregnancy continues? It increases. Yeah, it increases all the way up to like 10 weeks. Yeah, and the HCG is related to our early pregnancy symptoms. Yeah, so the rapid increase usually happens between 7 and 10 weeks of gestation, and this is usually the time where the woman will have the severe hyperemesis. Usually after 10, 11 weeks, it starts to drop, so the early pregnancy symptoms will actually disappear. Okay, so normally in a normal ongoing pregnancy, the levels of the HCG should increase. Yeah, so what we used to learn before, well, we used to know before, is that you should double your HCG level every 48 hours in a normal ongoing pregnancy. Double. Okay, and at some stage, we used to say that if you have an HCG level of 1,500 and you do not see an intrauterine pregnancy, then it's highly suspicious of an ectopic pregnancy. And we used to call that level as the discriminatory zone. Okay? All this is not true anymore. Yeah? Because a lot of studies have proven that the level of increase of the HCG is extremely variable. And it's even related to different races. So maybe Asian will have lower increase in the HCG versus Caucasians, and so on. Yeah? So therefore, nowadays, I mean, the average increase is 30% in 48 hours. Yeah? But sometimes you might see an increase of only 15%. So although the increase in the HCG will give me an impression whether this is an ongoing pregnancy or it's a miscarriage, or more importantly, it's an ectopic pregnancy, you have to, we can't really depend on just like one level. If it did not increase to the levels that we are expecting, we don't rush into the diagnosis of a miscarriage or the diagnosis of an ectopic pregnancy. We might need other ways of actually evaluating the pregnancy. Did you get that? And 1,500 is totally useless. It doesn't work at all, actually. Sometimes you can see levels as high as that 4,000 or 5,000, and you still don't see an intrauterine pregnancy. Why? What could it be? Okay, or? No, or multiple pregnancy. So the levels are high just because they are multiple, not because they are advanced in the pregnancy. So you'll not be able to see a sac. Did you get that, Banat Shabab? Yeah?
No, I didn't get.
You didn't get what?
Why do you have a very high level but still no intrauterine? If there's multiple pregnancies, then why can't you see it in the uterus?
Because there is a pregnancy, but it's still too small to be seen. So there's really no level of HCG that will tell you have to see a pregnancy at this level. Yeah? Because, I mean, like I said, it could be twin, it could be triplet. So the levels are very high just because there's a lot of trophoblastic tissue, but still it did not reach the stage where you can actually see it by ultrasound. Yeah. Okay. Done. So remember that there are other causes of bleeding in early pregnancy, such as molar pregnancy. And remember that a complete mole is present in 1 in 1,000 pregnancies. And there's diffuse hydropic chorionic villi surrounded by hyperplastic trophoblast. And typically in a complete mole, you do not see, there's no fetus. It's only Trophoblastic tissue, exactly. And all the cells are of paternal origin. So there is an egg that is fertilized, an empty egg that is fertilized by paternal tissue. So it's only paternal, there's no maternal, okay? It's so the maternal protein, which is the P57, is not expressed in complete mode, okay? So this is basically what you see by ultrasound here and by gross eye, okay? So what we see by ultrasound, we call it snowstorm appearance, exactly. So there's like a lot of like, you know, small like, you know, hypoechoic in the presence of hyperechoic areas. So snowstorm appearance, and by naked eye, you might actually see like vesicles, like, you know, like grape-like structures. The patient might present, you know, with bleeding and passing these grape-like structures. Okay. Risk factors for molar pregnancy: a previous small, extremities of maternal age, very young mothers or older mothers. Asian have a higher risk, and they say maybe diet low in protein, folic acid, and carnitine. I don't know how you can actually evaluate that, but this is one of the risk factors. Okay. What will the symptoms be? What happens to the pregnancy symptoms? Why? Exactly, because there's very high levels of beta HCG. And bleeding, that is actually not a lot. It's not like heavy bleeding, usually brownish. Sometimes, like I said, they might pass all these, you know, vesicles and so on. And rarely they have pelvic pressure or pelvic pain. Okay. Signs, طبعا, there's rapid growth in the size of the uterus. Sometimes they might develop high blood pressure. And what is that? Preeclampsia. So usually preeclampsia is a diagnosis made after 20 weeks of gestation, but there are some selected cases where they might actually present with early onset preeclampsia. One of them is molar pregnancy. Ovarian hyperstimulation, again, because of the very high levels of the beta HCG. Anemia, hyperthyroid, again, because the HCG is very similar to
TSH.
exactly, and very high beta HCG. Okay, how do we treat molar pregnancy?
You remove it.
Once we diagnose it, what do we do?
You remove it.
Huh?
You remove it.
You remove it. So it has to be surgical evacuation. Surgical evacuation. Yeah. And obviously follow up, because you don't want her to develop into. Exactly. So persisting molar pregnancy, or even worse, choriocarcinoma. And choriocarcinoma can actually happen after a simple molar pregnancy. On the other hand, a partial mole. What is a partial mole? So it's an abnormal placenta in the presence of a fetus. And this fetus is likely to be what?
Non-viable.
Non-viable. It could be non-viable. It could be viable. So why does a partial mole happen? We said in a complete mole, it's an empty egg that is fertilized by 2 sperms. Exactly. So what will be the genetic, the chromosomal makeup? Triploidy. Exactly. So 69, XXX, or XXY, or whatever. Yeah, so it's triploidy. And triploidy is an abnormal pregnancy. So these fetuses, they will not survive. Okay. Can you find a partial mole with a normal fetus? No, you can. It could be what? Twin pregnancy. Could be twin pregnancy. One pregnancy is a partial mole, and the other pregnancy is actually a viable fetus. Yeah. So it could. Okay. So here there are fetal tissue up, you know, with the, which is different than what you see in molar pregnancy, where there is no fetal tissue. Okay. Subchorionic hematoma, which sometimes we see that. We see like a collection of blood behind the gestational sac. Yeah. Many times these patients will present with some bleeding, although sometimes you might just see a subchorionic hematoma in the absence of any symptoms from the mother. Okay. So this is basically what you see in the height. This dark area there. Yeah. This is an area of bleed. Okay. Behind the gestational sac. And Usually, in the majority of cases, it will just settle. If you see it, you tell the patient she's likely to continue bleeding till she actually empties that subchorionic hematoma. Majority of cases, the pregnancy is going to continue. Obviously, if she has more bleeding, then she's at risk of having a miscarriage. But it's not uncommon finding. We see that quite a bit. Okay? So remember, when you have any patient presenting with early pregnancy complications, including bleeding, the most important part, like I said, it's an emergency. This is an obstetric emergency. So the most important part is to make sure that the patient is stable from the bleeding point of view, and that you will know that depending on the amount of bleeding that you have, depending on her vital signs, and so on. Obviously, if she has like heavy bleeding, then you need to resuscitate the patient. You need to start her on IV fluids. You have to take blood to cross-match. You might even need to transfuse the patient. So it's very, very important. While somebody is helping you to do all these things, for us, we need to decide on the prognosis of this pregnancy. Is it a miscarriage that is incomplete and the bleeding will only settle if I take her immediately to the OR to evacuate the pregnancy? Well, it's a viable pregnancy, closed cervix, even if she has bleeding, but my aim of treatment is conservative management. Or on the other hand, it's an ectopic pregnancy that needs also an urgent, OR intervention. Yeah, so it's very, very important to do all these things at the same time. And what will help you in addition to your blood work is your ultrasound, basically. That's the cornerstone for your evaluation. I mean, yeah, HCG is helpful, but once you are already seeing a gestational sac, you don't really need to follow up by HCG unless you are concerned whether this is an ongoing pregnancy or not. Or if you don't see a gestational sac, then an HCG might be important just to check whether you are dealing with an ectopic pregnancy. Okay? So hemoglobin group and say beta HCG and serial HCG. So what happens to the HCG in an ectopic pregnancy?
It increases.
Huh?
It increases, it's not as fast.
Exactly. So the rise is going to be slower than that of a normal pregnancy. It might actually plateau or it might even drop. Yeah? طبعا plateauing or dropping doesn't really confirm your diagnosis of an ectopic, and it still could be an unviable intrauterine pregnancy. Yeah, but if you don't see, if you don't see a gestational sac, there's always a risk of being an ectopic pregnancy. And then depending on the level of your HCG, you will decide further management. There is something actually called a pregnancy of unknown location. And we see that. I mean, just recently, I actually had 2 of my patients with pregnancy of unknown location. HCG is increasing, continued to increase, and I was not able to see a gestational sac. So what do you do with these cases? How do you treat them? Huh? If it's too tiny, you're not going to find it.
Like a seed,
Huh?
You give medications.
Exactly. So you consider it as an ectopic because this is what you're worried about. But if you can't see an ectopic, how can you treat it? How can you treat ectopics medically? I don't see where it is. How can I give it? How can it abort? Exactly. Methotrexate. Bravo, Aleki. Methotrexate. So that's the medical management of ectopic pregnancy. So if it's a pregnancy of unknown location, or even if it's an ectopic pregnancy and you know it's an ectopic pregnancy, but the patient is stable, the levels are not very high, and usually the levels anything less than 5,000, we can still treat it medically, and there is no evidence of rupture, then you can treat her by methotrexate. Okay, and the same for pregnancy of unknown location. Okay, so both of my patients actually received methotrexate. Just now, over the last 2 months, they were basically like 2 after each other, like within a few weeks of each other.
What happens after
The HCG starts to drop. At the beginning of the methotrexate, you don't usually recheck the beta HCG before 3 to 5 days because of the rapid, destruction of the cells, HCG actually increases. So you're just going to be worrying yourself and worrying the patient. So you wait for at least 3 to 5 days before you repeat the levels. And then it depends on the decline. Is it still increasing? It's plateauing, well, it's dropping. You will decide whether you need to give another dose. You might need to give more than 1 dose of methotrexate. Okay? Done. So we said transvaginal ultrasound. Okay, so this is what I was talking about. So somebody was asking earlier, okay, when do we see a gestational sac? Usually, a gestational sac can be seen as early as 6 weeks by transabdominal ultrasound. It could be seen as early as 5 weeks by transvaginal ultrasound. Okay? But then, and usually at an HCG of around 6,000 or higher, you will be able to see a gestational sac. But again, I always tell my patients, humans are humans. We are not robots. We are not machines. Yeah. So there's a big variation in humans. Okay. So you might have an HCG of 8,000 and you don't see a gestational sac, or you might see an HCG of 4,000 and you see a gestational sac. So there's a lot of variations. Okay. Once you see an intrauterine gestational sac, that almost excludes an ectopic. Why did I say almost? Because you could have a double pregnancy. So it's a twin pregnancy with one intrauterine and one ectopic, especially in IVF. Yeah, especially in somebody who has a tubal problem. Okay, so we call it heterotopic pregnancy. Okay, well, this is something very, very important, and everybody needs to be aware of it. So, like I said, the gestational sac is not floating in the uterine cavity. It's actually embedded into the wall. And therefore, where will you see it by ultrasound? So, is it central? It's off the center. So, this is a normal gestational sac. It will not be in the center. It's off-centric. Okay? In an ectopic pregnancy, you might see something that looks like a gestational sac, but the difference between this one and this one is that this is a bit more centric. It's irregular, bravo. And what is this usually? Just bleeding. There's really no tissue. There's no pregnancy tissue. It's only bleeding. And that's why it's very, very important to differentiate a pseudo-sac from a true sac. And many times, actually, people make mistakes. And they think, no, there's an intrauterine pregnancy. No, this is not an intrauterine pregnancy. This is only bleeding within the endometrial cavity. Okay, but the pregnancy is not intrauterine. Okay, so it's important to differentiate a pseudo-sac from a true gestational sac. Okay. So I mentioned earlier, there could be other causes of bleeding early pregnancy, like cervical erosions, like cervical polyp, cancer of the cervix, although they are less common, but we see them once in a while. Okay, any questions? So this is bleeding in early pregnancy. Okay, so we'll move now to bleeding later on in pregnancy. So we have a 34-year-old woman in her third pregnancy, unbooked to your hospital, presents to the labor room with fresh vaginal bleeding started 1 hour ago. She's 33 weeks pregnant. Yeah, she has no pain. This is her first attack of bleeding. Fetal movements are normal. There is no history of intercourse over the last few days because sometimes women bleed after intercourse. That's totally normal in pregnancy. Okay, she has a previous cesarean section, 2 previous cesarean sections. Okay, her blood group is ORH negative. Her CTG is reassuring, and ultrasound confirmed a normal fetus. And where do you think the placenta is? Previa. So what are the things in the history that will make you think it's a placenta previa versus other causes of bleeding in? The 2 previous cesareans, bravo. What else? Okay.
Bleeding in the third trimester.
In the third trimester, yeah. What else? Painless bleeding, very good. Painless bleeding. So painless bleeding, good fetal heart, okay. History of cesarean sections, all these will pinpoint more towards a placenta previa. So a placenta previa or bleeding after the 20 weeks of gestation, we call it antepartum hemorrhage. Okay, and it's not uncommon. It complicates around 4 to 5% of all pregnancies, and the major causes are placenta previa, placental abruption, uterine rupture, and vasa previa. These are the major obstetric causes. Obviously, there might be other causes, what we just mentioned about in bleeding in early pregnancy. So what is a placenta previa? So it's a placenta that is implanted in the lower uterine segment. Okay, it could be like totally covering the cervix, so that's a complete placenta previa. It could be just the edge is reaching into the cervix, so this is a marginal placenta previa, or normally it should be totally away from the cervix. Okay, it occurs in around 1 in 200 pregnancies. We do see a lot of low-lying placentas in the second trimester, but the diagnosis of placenta previa cannot be made before 28 weeks of gestation. Even if we saw a low placenta at the beginning, we call it low placenta. We don't call it placenta previa. Okay, so we call it placenta previa only if it remains after 28 weeks of gestation. Sorry? On the fetal size. It doesn't depend on the fetal size, but that's a good concept because the risk factors could be multiple pregnancy because there isn't a lot of space in that uterus for the placenta to implant. So the placenta needs to implant lower, especially if they are like 3 fetuses or something. Yeah. So yeah, multiple pregnancy is a risk factor for placenta previa. A previous history, previous cesarean section, smoking increases the risk. Older mothers, previous any uterine surgery in the past increases the risk of placenta previa. Okay. Like I said, we see a lot of low-lying placentas in the second trimester when we do our normal. We said yesterday we do our routine ultrasound between 20 to 22 weeks of gestation. Maybe 15 to 20% of the pregnancies of the placentas will be low at that stage. We only consider it low if it actually reaches the cervix. Even if it's like few millimeters away from the cervix, we don't consider it low. Why? What actually happens to these placentas later on in pregnancy? Okay, how do they move? Okay, so they don't actually move. What happens is that in the third trimester, after 28 to 30 weeks of gestation, the upper part of the cervix becomes what? The lower uterine segment, yeah? So the upper part of the cervix actually expands, and rather than being like 0.5 centimeter in length, it becomes like 5 centimeter. And that develops the lower segment. This is where we do our cesarean sections. Yeah. And we like that area because, what did I mention earlier? It doesn't have a lot of muscles, and therefore the bleeding is less, the healing is better. Yeah. So that's the lower uterine segment. So the lower uterine segment is actually coming from the cervix. So a placenta that was already away from the cervix or just reaching the cervix now becomes like 3-4 centimeters away. Yeah. So with the expanding uterus, it just gets pulled up. Okay. So unless it's actually reaching the cervix, well, covering the cervix in the second trimester, we don't need to recheck the placental position. But if it was, then we repeat the placental localization at 32 weeks of gestation, because this is the stage where we have already developed our lower uterine segment. Got that? Okay, we said that. So symptoms like what our patient presented with, usually fresh bleeding that has no pain or anything. On the other hand, a placental abruption, what will the patient present with? Pain is very, very important. So it's really severe pain, sometimes contractions, sometimes in severe cases, what happens to the fetal heart? So it's either fetal death. If you abrupt 50% of the placenta or more, the fetus will not make it. The fetus will die. Okay? If it's a smaller abruption, then maybe the fetus is still alive, but you just have to confirm that by CTG, and you might see actually fetal distress. Okay? Okay, we'll come to that. So risk factors for placental abruption includes preeclampsia. Patients with preeclampsia are at high risk of developing placental abruption, trauma, drug abuse, smoking, and previous abruption with 10% risk of recurrence. Okay, so placental abruption, we said what are the symptoms and why there is uterine tenderness. So it's not only contractions, but also uterine tenderness. Where could the bleeding occur in an abruption? Yeah, so it could be revealed bleeding, so she presents with active vaginal bleeding, or it could be concealed bleeding, yeah, so she bleeds within the uterine wall, and that's why the uterus becomes spongy with a lot of bleeding inside it. And what happens to that uterus after delivery? What did we say yesterday stops the bleeding? So is this uterus able to contract? It's not able to contract. And that's why these patients develop massive postpartum hemorrhage, sometimes to the extent that they might actually require a hysterectomy. Or because of the massive bleeding, they might actually go in DIC. So is it an obstetric emergency? It's a serious obstetric emergency. Okay. So this uterus, we call it Cavalier uterus. Okay. Uterine rupture is usually related either to trauma or can we induce uterine rupture? From what? Cesarean causes uterine rupture? Huh? Oxytocin, bravo عليك. Yeah. So كل اليوتروتونيc agents that could be oxytocin, but more importantly ايش؟ Prostaglandins, bravo عليكم, because it's actually a more stronger uterotonic agent. Okay. So, you know, uncontrolled use of all these medications can lead to uterine rupture, although spontaneous rupture can actually happen. And again, risk factors, it could be multiparity, trauma, excessive use of oxytocin, a non-cephalic presentation in labor, shoulder dystocia sometimes, or even forceps delivery. Okay? What's a vasa previa? Exactly. So we have a placenta, but maybe the cord insertion is a marginal, yeah. So you'll see maybe the vessels are crossing in the membranes to the placenta, and these vessels, if they happen to occur on top of the cervix, then potentially they can rupture. And where is the bleeding coming from? So, fetus, bravo عليكم. So the bleeding in placenta previa is what? Maternal. In placental abruption, it's combination. It's combination, fetal and maternal. Vasa previa, fetal. So therefore, in vasa previa, how much bleeding are you going to find? Not a lot. But what will you see on the CTG? Severe fetal distress. Yeah, لأنه the fetus, how much blood did the fetus have? 5? 5? Huh? So it's 80 ml per kg. 80 ml per kg. So a full-born baby at 3 kilos has 240, 250 ml of blood. Yeah. So even if you lose, I mean, if she's 32 weeks, for example, with a bleeding vasa previa, the weight is like 2 kilos, and the baby has like 150 ml. Even if he bleeds like 15 ml, that's already 10-15% of his blood. Yeah. So that's why you'll find little bleeding, but massive changes on the CTG, which makes you suspect a vasa previa. Okay, so this is basically what you see, vessels crossing on top of the cervix. Not an easy diagnosis. Yeah, I mean, you can look for them by ultrasound, but it's not an easy diagnosis. Other causes, everything we mentioned earlier. Now,
when the baby delivered like normal?
يعني usually the CTG changes are going to be massive that you cannot wait for a vaginal delivery. You'll have to deliver the baby by cesarean section. And depends on how bad the CTG was, and if you caught it in a good time, then maybe the baby will make it. Yeah. Not all babies die, not even in the placental abruption. Alhamdulillah, يعني. Yeah. Remember that any patient presenting with bleeding in the 3rd trimester, you remember what we said in early pregnancy. One of your evaluation is to do a speculum and vaginal examination because I want to see the cervix. We never do that in the 3rd trimester لأنه we do not do a vaginal exam on the placenta previa. And if you put your fingers there, you are likely to make the bleeding more. Okay? So I will only do a vaginal exam after I confirm by ultrasound it's not a placenta previa. Okay, and then I can examine, because I remember, I mean, bleeding could be simply related to labor. Sometimes women have some bleeding in labor with the dilatation of the cervix, so she might have bleeding. So you need to know whether she's actually in labor or not. Even placental abruption, if it's only like a small abruption and the bleeding is not very heavy and the patient is stable and the fetus is stable, you might actually allow her a vaginal delivery if she's already contracting. Okay, but remember, the first thing is to locate the placenta before you do a vaginal examination. Okay. And delivery, it depends. I mean, you want to consider a delivery in a massive placenta previa if she's already reaching a term. On the other hand, if she's only like 26 or 27 weeks and she is stable, you don't want to deliver her. And the same applies for abruption. If it's a massive abruption, you have to deliver regardless of the gestational age. But if it's a small abruption, the patient settles, the fetus is fine, you might want to do conservative management. Okay. And remember, this patient was Rh negative and she presented with an abruption, even if she delivered or she did not deliver, what do we need to give her? Rogam, exactly. But if she delivers 1 week later, what do I do? Do I repeat the Rogam? How soon do I have to repeat the Rogam? How long does the Rogam last for? Usually like 23 to 25 days. Yani just over 3 weeks. So if the patient has another attack of bleeding more than 3 weeks later, or she delivers more than 3 weeks later and the baby is Rh positive, then you have to give her another dose of Rogam. But any antepartum hemorrhage, any bleeding in early pregnancy, you must cover the patient. If she's Rh negative, you have to give her Rogam. Okay. Any questions? No? All clear?